This is the talk, the interactive discussion on early intervention from conception to community. And it is going to be interactive. The 5 speakers that we have today are going to introduce themselves. I'll quickly introduce myself. My name is Regina, also known as Reggie Harborn. I'm at Duquesne University in Pittsburgh, Pennsylvania. I do have an IES project that has been going on now we're in our 7th year, looking at early intervention, efficacy, comparison of interventions. And my area of interest is in infancy, 0 to 3, intervention for children with motor disabilities, but looking at the cognitive interaction of movement with cognition. So why don't we go ahead and I'll just call on you. So Stacy, do you want to give us just a little?
Absolutely. Thank you so much, Reggie. I'm happy to be here. I'm Stacy Duzing. I'm the Sykes Family Chair of Pediatric Physical Therapy, Health and Development at the University of Southern California. I am a co-PI or a co-investigator on the IES grant that Reggie just mentioned, as well as the lead PI on an NIH trial that followed up on that to extend the work in looking at medically complex children.
Okay, Sandy, you want to intro yourself?
Hi, I'm Sandy Willett. I'm a physical therapist by training. I've been involved in both of the research trials that Reggie and Stacy have mentioned. As a clinician, I've had my feet firmly planted in both the NICU, the neonatal intensive care, and the early intervention settings, and been a practicing clinician there for over 30 years. And I'm very interested in how we support families in both of those settings.
Great. And then Michelle.
Hi, I'm Michelle Lobo. I'm at the University of Delaware, where I'm an associate professor, and I'm also part of the amazing Start Play team that everyone has already mentioned. I am a researcher in the physical therapy department, and I have over 25 years now of clinical and research experience working with families with young children. And I work to really develop novel intervention tools, rehab technologies, educational programs, to educate parents about child development, trying to advance children's motor, cognitive, and now recently working with Roberta Golenkoff, language development as well. And I'm happy to be here and to interact with you all.
All right, and last but certainly not least, Lisa.
Hi, everyone. Good afternoon. It's really nice to be here, and it's really nice to be included as part of this Start Play team. I'm actually not a team member. I'm bringing a little bit of a different perspective. I'm a research faculty member in the Nebraska Center for Research on Children, Youth, Families, and Schools at the University of Nebraska-Lincoln. And I'm interested in prevention and intervention program teams to support family engagement during the early childhood period. And I'm also doing work related to professional development and training supports for early interventionists. And so have some work funded as OSEP through OSEP for that specific project. So happy to be here.
Okay, great. So this interactive discussion is going to talk about 4 things. We're going to discuss obstacles and potential solutions overall in the umbrella of early intervention regarding the amount of services that children get in early intervention, transitions between service providers and settings, and then 3, translation of current evidence to practice. So does the science get to the practice? And then lastly, needs regarding family supports. We also would like to just sort of touch on, I was just in the interactive discussion about how COVID has affected some research projects, but one of the participants or one of the speakers brought up really talking more about boots on the ground, what's happening out in the community, not just how has it affected our research project. So we want to keep that in mind, sort of moving through this discussion. And then we're going to go a little bit chronologically. So Stacy has a project that starts in the neonatal intensive care unit. And as you heard, Sandy also has experience in that setting. So we're going to start with Stacy first and ask a question of what barriers do you see or what barriers do parents report in the transition from hospital, neonatal intensive care unit or not, to home, and how does this impact their early access to intervention?
Thank you so much for the question, Reggie. So I do have a clinical trial looking at intervention from the neonatal intensive care unit to home. But as a practicing clinician with 30 plus years of NICU experience, we repeatedly hear the same thing from parents, that they get lots of medical information and maybe some information on early intervention before they get home. But when they get home, they're completely overwhelmed caring for their child. And that they often get a call from early intervention saying, do you have any concerns? And the parents say, no, not about development right now. So they don't get services from early intervention. And the challenge with that is, one, we're asking parents to know about their child's development with very limited knowledge about child development. Even if you have a background in child development, knowing what to expect from your baby in the transition from the NICU to home is very difficult. So I'm very fortunate that we have a parent advisory board that works with us, as well as have just finished a series of qualitative focus groups with parents to really make sure we're really understanding the message from families. And they are very consistently saying they are not getting adequate support from the NICU to home, and as a result are not getting engaged in early intervention early enough. One of the real challenges that I think we're also seeing, and that parents are reporting, is that even when someone does come out to do the assessment of their child, oftentimes the person who comes doesn't specialize in very young infants. And so if you're used to seeing 2-year-olds and you do an assessment on an infant who is in fact showing movement difficulty or feeding difficulty, but you don't have expertise in that area, it's very easy to under-identify the kids who truly have medical needs, as well as educational needs, and really a massive need for family support. So one of the major challenges is really trying to identify which kids need services and then plugging them into the services they need to support them. The last one that I'll mention is a challenge that I've seen in a couple different states that I've practiced in as well as done research in, which is the overlap or the challenge between medical-based insurance and early intervention service funding. And so in some states, if the child is still in the hospital, early intervention can't bill for intake or setting up the IFSP. So they wait until the baby goes home from the hospital. And then when the family goes home from the hospital, they're overwhelmed because they've now taken on all the medical caregiving. When if the IFSP is written while the baby is still in the NICU, and there's a known need for support services, the parents can really focus on that intake process and answering the questions and the challenges they'll have. This is a huge challenge because, of course, EI providers and the system needs to be paid for the work that they do. But if the baby's in the NICU and can't be paid, we end up having a delay in service delivery that may end up being months before the child can actually start services or even complete the intake process because families have lots of medical appointments to follow up on. So I think those are some of the major challenges that we're seeing. And of course, these disproportionately impact families who are already under stress because of issues within their socioeconomic system, their work environment, having multiple other children at home. So we know that there are significant racial disparities in this transition process from the neonatal intensive care unit or any hospitalization of a young infant and then into the early intervention process.
Thank you, Stacy. I did want to mention that if any of you have a comment or a question, you probably know this from other sessions that you've gone to, you can go ahead and type it into the chat of the Zoom, and then we can address that after we've gone through several of questions that we had prepared for you. So feel free to put a question in the chat, but we will also bring up a time for people to just sort of shout out their questions or raise their hand after we've gone through some of the questions we prepared.
Reggie, can I add to Stacy's commentary?
Yes.
So I just want to pick it up to talk about follow-up once you leave the NICU, if that would be appropriate at this time. Because in Nebraska, we're really fortunate to have a statewide program that provides developmental follow-up to all infants who are hospitalized for more than 72 hours. And we classify their risk based on the infant's medical acuity, not social or social economic demographics. Now, our biggest challenge is once babies leave the hospital, our ability to make first contact and schedule an appointment for follow-up after they leave is divided by their racial and ethnic self-identified categories. So you'd think of the Midwest as not a very diverse place, but the NICU that I work in actually has a racial ethnic demographic that's very similar to the national demographic and not to the Midwest. So we have a very diverse population, and our ability to make initial contact with families is determined by how they identify their race. We are less likely to make contact with the families who are racially diverse. The factors that affect whether or not a family attends is how old is the mom. Older moms are more likely to come back for developmental follow-up. What was the baby's birth weight? So the lower the birth weight, the more likely they are to attend. And 62% of the families who complete all follow-up with the developmental clinic are predominantly white. So we're missing a lot of the children who are at greatest risk, not just because of medical reasons, but for socioeconomic reasons.
What do you think are some of the barriers that that make that inequity present?
Well, one, they are less likely to be in the NICU to understand their babies and to be present at bedside because they don't have transportation. They may not understand the importance of developmental issues. And most of these families have other stressors that complicate the situation. They're more likely to have allocation of resources problems related to trauma. There's a lot of information out about trauma-informed care and understanding the allostatic load that families experience as a part of that. And we just know that the babies that are born into socioeconomic disadvantage already have barriers to overcome just related to that fact. And it's hard for the systems to understand the complexity, and the families are overwhelmed. They can't manage to navigate the systems on their own, and we don't always understand how to support them. We're not trained at the level that we need to be in order to support them during that course.
Right. Moving a little bit further chronologically, I wanted to kind of get everybody in at the beginning here. Michelle, can you describe some of the challenges that exist when trying to implement in practice in early intervention once a child is in the system? What's the science suggests is most effective for early intervention?
Sure. Thanks, Reggie. So the first thing is that early intervention science has been very effective. We have found key ingredients that are consistent across, we're talking about START Play today, but there are multiple other early intervention trials that have identified similar key ingredients to the ones that are included in our intervention. And so you would think that that would be easy to implement into practice, but the reality is we've had many conversations with our group about our annoyance about continuing ed courses for therapists. There is a business model for educating individuals, and the education that those individuals receive is not always focused on evidence, but is more focused on sort of a cookie cutter approach and some special technique. You pay a lot of money, you come out knowing it. So I think that's a challenge for us as researchers, all of the researchers who are generating this information. How do we actually translate it into practice? Because it's not enough to say these are the key ingredients. People don't know what that actually looks like when I go to treat my child, and what activities should I be doing? How should my time be allocated? They don't know how to implement that information, those principles, just by saying them. So we need to get ourselves into this game of marketing, sharing our interventions in ways that people want to receive them. The other big challenge is that what we all love about development is that developmental science shows that kids are, this holistic creature. We can't break them up into parts. Even if we want to break them into domains like we do in the literature or, in our research expertise, or we do medically, by having specialists in each area, we can do that, but we can't ignore that the child is a whole. And the early intervention science suggests that these interventions that are not just domain specific, but include activities across domain. For example, our Start Play is not just for business as usual. We found people are mostly just doing motor activities, and kids do well with their motor development, their gross motor development. But when we add some icing on the cake and we let you do those activities in a social context and along with cognitive problem solving tasks, then you actually have these other benefits that we see as well on top of the same motor benefits. So if we are supposed to be treating children across developmental domains, how do we do that in our current system? So, one model is to send in the one professional that is trained a little bit in every domain. But I don't think that works really well. We need to actually figure out how much of an expert you need to be in each domain. Otherwise, you're missing everything. There's nothing that you're really knowledgeable about. If we continue with our current model and we have individuals who are experts in a particular domain, how do we decide how much education then is important for them across these other domains so that they can integrate them within their practice? And that's not something we should take lightly, because right now we have a big problem with graduate education, especially. It is incredibly expensive for people, which deters people from coming. It leaves them with lots of loans afterward. And then we're asking you to go into early intervention when you have this expertise that you could take into other settings and make a lot more money. So if we want you to go into early intervention and treat people, and we want you to be trained specifically with your area of expertise, but also know about these other areas, we need to think about how to effectively train you without increasing the cost of education for you. And then we need to think about not only our training and our models of service delivery, but also our models for billing and effort documentation, because it used to be my favorite thing to co-treat with people, because then you learn about somebody else's expertise, you can carry that over, and it's extremely beneficial for the kids you're working with, because then, my activities and my knowledge can be carried over into this other therapist area and vice versa. But now billing and effort documentation often requires that people only can document, 1 minute for one person. So if we have a 30-minute session together, either you get credit for that or I get credit for that. And that system just doesn't really foster the type of collaboration and transdisciplinary care that we need. So I think those are two of our biggest challenges, really addressing this, what the science is about the child being a whole unit, and then also, how do we actually get people to understand these key ingredients?
I think we're identifying a lot of sort of structural issues within the early intervention system. Sandy, there is a question. I want to just hop back to you for a second. There's a question in the chat that says, can you clarify who the we is for not being able to support families who experience economic hardship in accessing supports as they transition out of the hospital? Are you referring to early interventionists?
Actually, I'm talking both to the medical teams that support families in the hospital. I don't think they understand the complexity of families, and the early interventionists as well. I think I was thinking of professionals in general who work with early families, don't always understand the cultural and diversity and complexity that they're dealing with.
Okay.
Thanks.
Yeah, thank you for that question. Well, let's actually move on to Lisa, because Lisa has a lot of experience with sort of training and parents. And the question for you is, how can service providers more effectively partner with families and reduce inequities in service delivery in early intervention? Oh, can't hear you.
Thanks, Reggie. And in fact, I think it's not by mistake we're going in this order, because it really does build on the comments that Stacy, Sandy, and Michelle have shared to date. I was thinking, Michelle, as you were talking, that the professional development and training that you're talking about specifically is probably is discipline specific, is kind of child centered, and therapies and the kinds of things that we know that interventionists could provide to help children. And so the work that we've been fortunate to conduct in Nebraska has focused specifically on family engagement and sort of the way of doing business with families. So how we then move that content into settings with families to make it most meaningful. And I think it creates some challenges in that it's adding yet another layer of skills onto the service provider. So not only do you have to know as a professional how to do the important work of your discipline, but then you also have this added dimension of how do you then carry that out and know how to engage most effectively with families to partner with them in whatever setting that is. And I think to your point, Sandy, that professional, whether that professional is the NICU professional or whether that professional is the early interventionist in the home. But so we have been fortunate to test and trial the Getting Ready Parent Engagement Intervention, which is a set of strategies and an approach for working effectively with families. And we found that to be important and really augment the services of early intervention, particularly in the home. We haven't had an opportunity to do this in NICU settings, but we're certainly talking about that. And that's something I know that Sandy's interested in pursuing as well, how we can really support all professionals as they're thinking about their work with families. And so I think one added dimension that becomes really important is the support structure around doing all of this. So whether that's the transdisciplinary kind of work, whether it's working with families, what kind of support structures do we have in place to support professionals in this really challenging, increasingly challenging, always challenging work. And I think another area of research potential is continuing to explore these support structures to guide, professionals and early interventionists as they're doing this work with families. But I think it certainly is not only with families, it's the more content specific work as well.
So I'd like to maybe go back in the same order, and we can start with Stacy and go Sandy, Michelle, Lisa, and ask about, we've sort of identified some problems, but perhaps you have some ideas on structural areas that could be changed. And I know that systems are not the same from state to state, but are there any things that you have discovered in your practice and in your research that would be a start in the right direction to make some structural change related to the problems that we're mentioning and equity and inclusion? So Stacy, do you want to start with that?
Yeah, I would love to. And I do think that there is a lot of potential out there for things that we can do. And so the clinical trial that I have that's running from the NICU to home, we actually have modified into both telemedicine and in an in-person type intervention. And so the goal really is to work with families for about the 3 weeks prior to discharge, to work with them on preparing to take this baby home and to thinking about how do you scaffold and support development. And really the intervention is focused very heavily around parenting and how do you engage. And with 5 visits over 3 weeks, we really get parents to the point where they feel like, I can do this. I can support development, not only worry about the medical issues. And so in our current trial, we actually have a group that starts in the NICU, and they do these 5 visits in the NICU. And then they do 5 visits at home spread out over 3 months. And we've done some really interesting qualitative work with parents to get feedback in our early work, and then are doing that again now. And it was really interesting to have a dad say to me, it was really hard to keep doing this intervention as we transitioned to home. But after a month and a half of doing it, every day we asked him to fit it in for 20 minutes a day. He said it was like breathing. Versus the parents that we start at 3 to 4 months after discharge, they don't pick it up the same way. because I'm asking them to change how they parent instead of collaborating during the build of how do you care for a medically fragile child during the transition from NICU to home. And so I think one of the things that we could do that would be the most effective for changing outcomes for kids and getting families prepared to support their baby for potentially the next 2 to 5 to 10 years, where their child may or may not have developmental issues and need ongoing early intervention. But by helping them transition and recognize development is super important, you're your child's first teacher, and let's support you in this transition to home. It says development is important and it matters that you start today. As we move towards having better early detection guidelines for early developmental disabilities, we're able to identify which kids are at higher risk. By 3 to 6 months, we start to get a pretty good inkling for who's going to have cerebral palsy, for example. We actually could have supported that child from the NICU till 6 months and already be heavily engaged with that family when they either get the news that, you know what, your baby's looking great and I don't think they need ongoing services, in which case we save providing services at an older age, or when they get tough news that their child's at the highest risk of having a long-term and lifelong developmental disability, in which case we're right there to step in and both support the family and continue services that are the most evidence-based.
One of the things that I know we've encountered in our Start Play study is recruitment to be in the study, and we have ended up with a higher socioeconomic status group than we know is out there because of the people who signed up for our research project. So I'm wondering if the panel members, and I totally agree with what you're saying, Stacy, but I'm just wondering about the inclusion and equity aspect of pulling and keeping a connection with those families who are low resourced, because it's always been a problem.
And I would say, Reggie, that in the Start Play study where we started the kids at 7 to 16 months of adjusted age, that was definitely a challenge. Even when I was recruiting, in one location, the sample that we enroll both from the neonatal intensive care unit across Virginia, we have one site in Virginia, and then the kids that we can enroll in Los Angeles, where I now live, our socioeconomic status is substantially lower than it was for the Start Play study. In Virginia, the population that we have enrolled in our clinical trial, that's 90 infants, is more than 50% Black. And in Los Angeles, we're enrolling at about 30 to 40% of families who are Spanish speaking and have Hispanic background or Latinx background, and a large number live in poverty. But it is only when we recruit from the NICU, because those families see the value early on and they stay engaged, and we don't lose them to follow up. Our dropout rate is less than 8%. Across our studies. And that's in the time when most early intervention programs lose a large number of kids. If we look at some of the national data on preterm infants, less than 50% get into NICU or get into early intervention over their first 2 years of life because of those gaps and the translation. And so we're losing well less than that in terms of our kids. And I think a large piece of it's that making connections early.
I wanted to bring up one other question just for anybody on the panel, partly because Amy Sussman suggested that we talk a little bit about the impact of COVID on early intervention, not just within a research study, but in providing service and training parents and therapists being engaged with families. I wondered if anyone could comment about.
I'll speak up for just a minute as both an EI clinician and a NICU follow-up person. We swung all virtual with our developmental NICU follow-up clinic. We had great attendance, but what we did find was greater than 50% of the kids were referred on for some sort of an in-person assessment. And it depended upon which time point it was. This looked at across all time points, but it got greater over time, in that we didn't feel like we were getting enough information from the virtual assessment and ended up referring those children on for a more in-depth assessment with an in-person team. The other interesting request is we got a lot more requests from families for medically related PT, OT, or speech services because all of our EI services had swung virtually, and they were very dissatisfied with getting services in that format for babies less than 3, at least in our Birth to 3 program. So we saw less parental engagement during the virtual aspect of EI delivery.
Lisa or Michelle, do you have any thoughts on the?
Yeah.
Oh,
Go
sorry.
ahead,
Go ahead.
Michelle.
No, go ahead,
You go.
Lisa. All right. So in our area, I do know anecdotally. So I did look up the research too after Amy posed that question, and research takes a lot longer than the pandemic even has been happening. So there are a lot of like case studies reporting about how people have switched to virtual modes, but there was not any stronger type of study design yet about intervention or the impact of COVID on intervention for early intervention. So anecdotally, I do know that referrals have been down. And I don't know if that's because doctors were busier, not noticing, even more under identification, or because they were worried about sending kids for services, or families weren't following through with the referrals because they were concerned about contact with someone else. So I do know that referrals and services have been down significantly for early intervention, which is really concerning. I also know that anecdotally, the daycare centers that I work with and the educators are extremely concerned about infants' language development because with mask on, it seems like there is much less babbling, a lot later language development, which makes you ask really interesting questions about the importance of seeing someone's mouth moving, right? And imitating that in language development. So I think there are big concerns developmentally for children, especially young children during COVID, but I think rates of services have been much lower than they even normally would be, which is already low because we're under identifying kids.
One of the things that we learned through this process was to that significance of the relationship between provider and parent. So we had spent pre-pandemic, the state has invested heavily in this family engagement approach as a strategy. And so unexpectedly, I guess that wasn't our research question, though, it provided an opportunity to learn the impact of having this intentional structure that focused on partnership and how important that became as visits had to move virtually. Those providers who engaged in getting ready visits with families and had the structure and strategies for interacting with families were reporting that they were feeling they had a relationship previously and partnership that they were it was much easier to maintain in the virtual environment than the situations where they didn't have those partnerships. So kind of just pointing again to that importance of connection with families was really important in moving to the virtual space. It didn't solve all of the problems, certainly, but it was something that was really important. I think something else that is an ongoing issue. So we're trying to implement coaching structure across the state for supporting these evidence-based practices, and in our state, and I'm sure this is happening in other places, but we're seeing a lot of turnover in staff and a lot of retirement of providers. And so these staffing shortages and structures are, I think, only exacerbated by the pandemic. Things were already challenging, but that's expedited some of those departures from the field, leaving gaps. So trying to give people extra roles around training and support in these particular domain areas is challenging for systems. We don't have enough people to do the basic level of coverage, let alone adding another level to provide support around particular techniques or supporting family engagement or perceived extra, sorts of strategies.
Yeah, I would love to just chime in real quickly and comment on what Lisa said about when we're asking people to do extras. One of the things that we have found with our families is that when we ask them to do things virtually via COVID, the length of intervention visits got shorter And when we asked them to do assessment visits remotely, if it was a very kind of overview clinical visit like that we were doing in our NICU follow-up clinic to just make it, do you need to come in? They could handle that piece. But when we asked to do research level visits or in-depth visits, the demand on the families was exhausting. And so we've been tracking the number of families who consent to do research assessment visits remotely, and then who will consent to doing it again. The numbers drop off drastically. And if we offered that they could come into the lab, we usually do our assessments in the home, but during COVID, there was a period where we couldn't go to the home, but they could come to us. We had families drive an hour and a half to come into the lab versus doing it virtually again, because it was so taxing to do an assessment virtually. And our families who had multiple kids at home and were trying to do an intervention visit while juggling the phone, and they would cut the intervention visits shorter. And we're very sensitive to reading family stress. And a part of the intervention is around how the family is perceiving what you're asking them to do. And so if we think about it from that perspective, we're also cutting the dose. So maybe the quality of intervention's gone down, but even the dose has gone down. And the way that it was the most effective was if we already had a relationship with the family. And so, as I mentioned, we have one group that starts in the NICU that we do things in person. Even during the entire pandemic, we were allowed to recruit and can start intervention in the NICU because we were already there. So we didn't increase risk. But our families who had the delayed start, where they met their therapist for the first time remotely and they started the whole process, they dropped out of intervention. Their intervention visits were shorter. And it was much harder to keep them engaged. So again, I think it speaks to that. If you have a relationship with the family, it's a different thing to go virtual than if you're trying to establish a relationship with a family, over the virtual world.
I have a question. We've talked a lot about the child and the family, but one of the points that Michelle brought up was sort of the therapist who perhaps is not following evidence, or perhaps they go to a workshop but cannot carry it through to actually use it within their intervention or their practice setting. So I'm wondering if you all have some suggestions for changing interventionists' minds, how that can be done. And basically it's how to translate the science that we're finding, some good results from the START Play study, how to translate that so that it actually has uptake in the community. And anybody in the audience could also chime in if they would like at this point.
Yeah, I'll start with just a couple of thoughts. So I think it's maybe you start by changing behavior, right? So I think most people, if they hear, oh, you need to have meaningful activities, they have to be fun for the child, they should be within a social or a kind of context, you have to work on brainstorming with parents, all these sorts of things. Probably people will buy in and probably they will think that they're already doing that. But then providing clear examples to people, I think can be really helpful. So, examples of maybe on a continuum, because we're always talking about a continuum, right? We can always improve our communication, or we can always improve our brainstorming. So it's not even a good or a bad, it's not setting it up as a right or a wrong, but along a continuum, what might be lower level communication, what might be richer examples of communication. And I know that in putting some of Reggie's working to lead some continuing ed efforts for the START Play study, and we have a really nice library of those types of examples. I think people seeing those types of examples and seeing videos of themselves, which we've also done in our educational program, seeing videos of yourself and then seeing, when you look back at it, it might not look the way that you thought that it went, and you might see some examples of how you could have changed the pathway of the session a little bit. So I think that type of coaching, going through your own videos, talking through those, having examples of, along the continuum for each of the constructs or the key ingredients that you're talking about, I think those things can be really helpful for people so they can think about exact, behaviors they can mimic and activities that they can implement.
Let me add to that, Michelle. I think then creating something we have to do systemically is creating the time and space for reflection to allow that, because I 100% agree with you. And so kind of an additional add for the system is, how do you create space and time for people to be able to do that? Because it does take time to pause and think about what I did in this situation. Why did it work? Why didn't it work? And whether that's a peer, whether that's somebody else that's helping guide that reflection, I think that can be so powerful. And as I guess a call out to say we need some more time for people to actually have that space to do that really important work. I think if we can get enough people that have a positive experience and become allies and advocates, we've seen that be powerful within districts and systems, that just try a member of the group that's trying to do this work, not the research article that says it's effective, but that I worked with, the X family and it made a big difference. That's been powerful for our group of participants.
As a clinician, Reggie, I'm just going to tell you, you have to be a bit of a nag, and you will understand that, because you have to have an accountability partner that drives you forward. And it was really, really hard for me to shift my thought paradigm to a new paradigm that blended cognitive and motor. But what sold it, it's not the evidence. I love the evidence, but what sold it was the light that went on in parents' eyes when they were like, this is different. And I get this, and I see the change in my child, and that's all it took. And that's the place that you have to get people to, is where they actually, it's not just that you're taking it up, but it's that you can present it to a family and see the uptake as well. And that was what shifted my mindset.
I think one of the interesting things we have to could think about as we think about paradigm shifts is many of us as educators in the world of education and higher education or in primary education over the last 2 years have flipped to a flipped classroom, essentially, right? You deliver content over Zoom, but the question is, can you get people to actually then implement that piece of it afterwards? And so I know we had a large clinical trial that was funded in Australia that I was supposed to be traveling to Australia the summer of 2020 to train interventionists for a 400 child trial. And we had no choice but to flip it. And so we did all the didactics remotely. What I used to do 3 days of in person, we did 3 days of over Zoom or through lecture-based, sections of video. And then the interventionists had to go out and demonstrate on children. And we would come back in small groups and discuss the video. And I think it opened the time to think that Lisa commented on, because it brought the interventionists back to be able to say, this is what I did. And it wasn't a criticism of how they did anything, but it was a group think around how each person tried to implement things. We could look then at the fidelity of the interventions and talk through those pieces of it, all while I was an ocean away. And we were able to still give feedback. And since then, as the teams have flipped, actually have gone back and forth several times from remote intervention to in-person and back to remote currently, they've been able to still maintain fidelity, whether they're providing the intervention in a hybrid model of in-person in the NICU and then remotely once the kids go home. But it was just a very interesting approach that I think about continuing education. Now, we usually do one or the other, right? You come on site and do continuing education, you learn the information, we expect you to go home and practice it with nobody to give you feedback, or we expect you to do the entire thing online and then again, not get feedback. I think the idea of having people train and then come on site to do the hands-on or to do the actual group think around videos of what they've already done may be a more effective way to get that translation into practice.
That's one of the good things about the whole pandemic, right? Is that we had to make a shift in how we do some of our meeting together and brainstorming. And I know we happened upon a good hybrid model for the Start Play project, which we've done, in the United States because we had to, because we were supposed to present at a conference and we couldn't. So we made it into, asynchronous training and then a synchronous case study sharing. And we've done the same thing for people in Israel who did it last week, who wanted the training. So it's sort of broadened the audience that we can reach. So that's it's the good part of COVID, if we can say that. I'd like to know if anyone in the audience, here's a question. Are there other things that we as researchers can do to impact structural changes, perhaps new approaches to research results dissemination? And that's from Amanda. So I don't know if you had something in mind, Amanda.
No, I mean, I think actually, as I was typing it, Stacy started to address some of these things, but I think Lisa started to allude to this, right? Like, so there are new things that we're learning, but it's a matter of sort of getting it into the hands. So I don't know if there are new audiences, perhaps they're policymakers. I mean, I think, Sandy, when you were talking about funding, or Michelle, I can't remember who said it. Someone was talking about funding conflicts. When we know what works, but we're not able to affect these sort of larger changes, are there new ways that we can think about influencing the right audiences? Does that make sense?
Yeah, I think that does make sense.
I think it does, and I think it maybe points to some of the research questions. So some of the things that we've raised are our experiences doing other research about other things, but this is, what we've run into. So maybe we need, maybe that helps advance the conversation to actually have some data around the challenges that these structural situations actually create. And I think I don't know, at least in my experience, I've run into them, but I haven't studied them. And so do we need to broaden our teams in this space to say, I'm actually studying this, but here are some of these structural issues that are in place. And this is what actually results. We see a better outcome when in this situation, in a blended rated kind of funding or in this particular kind of service delivery approach. So in terms of research, maybe, there's some more some different questions we could be asking. And then, I do think this, who we're disseminating to and actually how we're getting information out and maybe creating more of a demand from the parent side of things that we sort of are relying on. To Sandy's point, I think we're relying on the information to filter through professionals, which certainly makes sense. But if families knew some of these things were available to them, would they be making more of a demand for these kinds of services and change in structures? And that would be really exciting.
I think you nailed it, Lisa. We need to be selling it to families and not just to professionals.
I wonder, so I'm coming at this from sort of a slightly older child perspective, like a special education perspective, but I'm thinking many of these families maybe have older siblings, but I almost wonder if there's something that this, the special education world can do to kind of disseminate even help, because they have those connections often already with the family. So another sort of outlet for disseminating the really early intervention work.
Yeah.
Yeah, I was going to say, I think I've become a chicken when it comes to working within systems that are too big and overwhelming. So I try to figure out ways around them. So for instance, in my lab, we make a lot of wearable technologies. So like braces that are soft or, soft robotics. And for everything people make in my lab, I make them make a DIY manual with very clear instructions and material lists. And so we can disseminate that immediately to the final stakeholders. We don't have to go through FDA approval or, anything like that. It's just you making a device, right? And so people are using that all over the world, those things. And so that to me is like, okay, let's find a workaround. And so I'm thinking the same way about this issue of like under identification and getting kids into services. And I like this idea of going right to the stakeholders. So we've been doing a lot of questioning of parents and talking to parents and surveying parents about where they are looking for information about child development. So if it's, 6 months to a year or longer that you're not getting services, you're still with your child every day and you're shaping their development. So are you looking for information about that? And the fact is they are. Where are you looking for information about that? They're looking online, primarily online or with family and friends. And so what does it look like, the information that they're getting online? And so we've been doing this huge quality analysis of the information. Who's providing the information? Most of the time you don't know. Other times you know, but it's never really an expert. A small percentage of that information is from experts. And then when it is from experts like the CDC or American Academy of Pediatrics, it's lists of milestones. It's not what to do with your baby every day. It's just, here's what's going to happen, sit around and watch. If it doesn't happen, tell your pediatrician. So it's not really based on current developmental science. So we've been thinking, I like this idea of thinking, how can I sneak around the system? Because there are many ways we can change the system, right? There are so many steps along the way we can identify facilitators and barriers, but sometimes for me, it's easier to think outside of that existing system. And so how can we broaden that and look at other areas people are trying to get education and change the quality of that education to change parent behavior and child outcomes? So that's one thing that we've been doing a lot of in our lab right now. It's certainly not a substitute. It's just sort of a parallel course that you can take, but we still need to also improve the early intervention system itself.
I love the idea of working around the system. I just want to add one caveat to that, is that the families who are out there looking for information and who are finding those resources are also our advantaged families typically. So it really causes racial and ethnic diversity challenges and socioeconomic challenges if we're not providing information equitably. And so we have to think about that from a language barrier standpoint, to a time, to an internet access standpoint, that I wish the system could do it within the systems. And I think if we're going to go around the system, finding a way to reach out to groups who are supporting or who are embedded in the community as players is so important to make sure that that everybody has access to this information.
Someone put a comment, Molly, another target audience are state level programs. Many state Part C programs are investing in professional development in these areas. So I know that Sandy, Stacy, I don't know, maybe you and Lisa and Michelle also have been involved in sort of state level.
Yeah, and our partnership too, we're Pat Snyder and I were both from the state of Florida, and the state Part C program here has been partnering us for a while to really make investments in professional development for EI providers in the state. That's one of the more challenging setups among Part C programs, and then it's fee for service and all of that. But they've really made a conscientious decision within the last 5 years to make these investments, and now we're through the grant that we have, we're having the opportunity to evaluate it and take a look at what are the outcomes at the provider level and family level. So I think that there is an appetite. We have done some work in other states as well. And I think that they, I don't know, it's always a challenge within the state systems because they have their own policies and procedures that they're limited by oftentimes and have very little control over, in our case in Florida, what they've done with Medicaid and other, intersections like that. But at the same time, I think that they are starting to see and really are, embracing a more caregiver capacity building model across the birth to 3 span, but they don't necessarily know how to get there. So I don't know, I think we've got some real opportunities when we have partners at that level, who have that sort of appetite for change and understand that there are evidence-based ways to reach that end goal of everybody implementing high quality early intervention from NICU to transition.
Yeah, it's a good point. And then we have another comment from Peggy Hester about working in a regional intervention program, a database parent implemented early intervention program. One of the most effective aspects was one parent telling another parent about the positive effects of the intervention. Yeah, parent to parent. I think there was a program like that in Nebraska, parent to parent, but I don't know whatever happened to it.
Yeah, even that the research is really clear, even for like early breastfeeding, for example, that if people come to talk to you who look like you or from your community and they talk about their experiences, then you're more likely to implement that behavior. So I think that that's really important. So not maybe even just another parent, but maybe another parent that you can identify with.
Yes. I also am wondering a little bit about, I know IES has partnership with NSF, National Science Foundation, but a lot of what we're talking about very early is this intersection between medical and educational, and whether or not, as far as I know, there haven't been these sort of dual funding of IES and NIH, but that would be perhaps an interaction that would be helpful for these very early ages that we're talking about. I don't know.
Yeah, and for later ages as well, right? Because many kids with developmental disabilities get care in the school as well as maybe outpatient or other types of services. And, you know, we've always struggled with that kind of disconnect.
Mhm. Amy, I see you turned yourself
Oh,
on.
yeah. I mean, no, you're right. We do have partnerships with NSF in a way that we don't with NIH, but I think that is a great idea, particularly for this area, this field that you're talking about. And I would love to talk to you about ideas in this area further. Happy to hear it.
Great. That would be a great outcome, action item that we could say came out of this meeting.
As someone who has my foot in both worlds, I can't tell you how different they are. We take babies away from families in the NICU to care for them, and families watch, and it's really hard to get them engaged. And if there's one policy change we could make, it would be giving greater family leave so that families could be in the NICU as much as they wanted to be and have access to their baby. And then we need this common language between the medical providers who get them well and ready to go home, and the early intervention team that's going to take them through the first 3 years of development. There's a huge disconnect there. They don't speak the same language. They don't have the same expectations of families. They don't have the same understanding of family dynamics. And so if you're not talking the same language from the beginning, it's really hard to understand and navigate that system.
And I think most early interventionists are very used to just sort of going in the home kind of blind. You don't get that information from the medical team that would be so helpful. We get it from the parents, which is, you know, we depend on them for that information, but it should be a full team approach. Any other comments that people wanted to just get out there? We have 2 minutes left. I just got the 2-minute warning from Oz.
I would love to flip a question to the audience about kind of this idea of really young. You know, I know many people in the audience are probably providers or researchers in this area. And for me, one of the challenges is, again, if you're mostly working with kids who are 1 to 3 or 3 to 5, is it a reasonable expectation for you to come to the neonatal intensive care unit and feel safe working with a family and a baby, or to do that as soon as that baby comes home with a feeding tube and oxygen? Or do we need teams in most locations who are specialized in infants? Is that something that feels feasible? And I'd love to hear other people's thoughts on that, because I clearly have my own.
Well, I'll jump in. I'm not an audience member, but I have a perspective from a rural state that that would be challenging in a rural state in terms of having that. We'd have to look really creatively about how to provide that support. So I think it's valuable and important. I think about the practicalities of it in a place where we have some low population and resource kinds of issues.
I wonder if maybe the biggest challenge to that is what Sandy said, and that the models may be so different, so it really, I don't think it's an unreasonable expectation that people understand and can work within that developmental time period. But because the nature of the interactions with families might be so different, that's really two different, they have to switch hats to really be able to navigate home and hospital. Seems like that would be a pretty big challenge.
And I agree. I love your comment.
I just think there's so many EI providers who are already trained in both worlds, right? Like I'm an SLP, I've been in NICUs, I've been in homes, and I can do both. Like there are so many of us who can do both. There's no reason why we can't train other people in Part C to learn how to talk to medical professionals and vice versa. Like, let's get on it. Let's get talking.
'Cause we need to
Totally.
train the families to do it eventually anyway, right? Even if they're getting EI, they go to doctors and they need to be able to tell the doctor what's happening developmentally. As a provider in a NICU follow-up clinic, I can't tell you how many families come back and say, I don't know, there's some person who comes to the house. I don't know if they're a PTO, TEI, outpatient, educator. I have no idea who that person is, but they come occasionally and they tell me to do stuff. So we would love to have more dialogue back and forth from a parent perspective, but also a provider perspective.
There is a comment from Dr. Becky Landa. Topics and information shared is exactly what we see. This is complex territory. A full day meeting on this would be really nice. So another action item, maybe we could pull a full day meeting together.
Yeah, we've run out of time, but I just want to thank everyone on this panel. This has been a really interesting discussion, and I feel like it could have gone on longer. Yes, definitely, absolutely.
Yeah. And there's a few more comments in the chat if people want to take a look at it. But yes, we have run out of time. Thank you all for your attention, and thank you to the panel members who did a great job. All right. Take care.
Thank you, everybody.
Thanks.